Welcome, everyone, to our third conversation in our 2026 Public Health Speaker Series. As we allow people to log on, we're going to give folks about 5 minutes to get settled. Um, Check your chat. We'd love to have you indicate, say hello, number one, as you join us. And also let us know where you're coming from if you're representing a particular organization. We'd love to see that information in the chat as you join us. Perfect timing. Great work. I think we have a DJ who is also a faculty. Thank you, Dr. Wilson. Welcome. Good evening, everyone, and welcome. This is the third webinar of our 11th season of the Touro University California Public Health Speaker Series. I am Gail Cummings, Director of the Public Health Program, and I am joined by my colleague, Dr. Deirdre Wilson, who is Chair of the Community Action for Health Concentration. Together, we host the series, which also serves as a course for our public health students, and it has done so for more than a decade. The series has brought national experts together to tackle complex and timely issues that are shaping community health as well as global health. This year's program focuses on two key themes. Our first two sessions so far have explored the rise and impact of misinformation and disinformation on public health. Today, we are shifting gears a little bit, although misinformation still is something that we will be kind of learning more about, but we'll shift gears to open a new thread in the series, looking more at the health experiences of newcomers in today's political climate. We are so honored to be joined by two phenomenal scholars, Dr. Tina Sachs and Dr. Maria-Elena Young, who will help us think more deeply about how policy, environments, and social contexts really shape health, belonging, and well-being for immigrant and refugee communities across California and the U.S. These conversations really do remind us that the work of public health has never been more urgent. Misinformation isn't just confusing, it's extremely dangerous, especially for those already vulnerable populations. And at this time, local policies continue to determine who has access to health, safety, and opportunity. So change really begins at the community level where its impact is felt most firstly and most powerfully. And this year's theme, Navigating Uncertainty, Public Health in the Face of Information and Misinformation and Transition, really ask us to stay steady, keep advocating for for the well-being of women, marginalized populations, and really those most at risk. And so to start, I'd like to take a moment to ground us wherever we are. We are on indigenous lands where languages, traditions, and ways of knowing and wisdom have always existed and still exist to this day. And as we gather to talk about immigration, migration, and belonging, it feels particularly important to honor indigenous traditions of telling the truth, truth telling, community care, and collective well being, which, these are the values that remind us of what honest, healing communication can actually look like. We also honor and remember that this country was built on the labor of enslaved Africans, and we honor the enduring strength and contributions of their descendants. And we also recognize immigrant, trafficked, and undocumented workers whose labor continues to sustain this country and our health systems every single day. So as we move into today's conversations, let's really hold these truths with care. Let's keep asking ourselves, as students, educators, and practitioners, how we can use what we learn here to promote truth, equity, and accountability in our classrooms, clinics, and in our communities. So thank you so much for being a part of this conversation and this important dialogue and for joining us today. Now I'm going to turn it over to Dr. Wilson.
Good evening, everyone. I have the task of our housekeeping this evening. This is a reminder that this is a Zoom recording, just to let you know that you are being recorded. A reminder to our students, again, that this is a course and there are required commitments for the course and deliverables. So please go to your Canvas course if you're unclear what deliverables are required for the course. So the roadmap for this evening, today's presentation, as Dr. Cummings said, is an overview of how policy environments shape the health of newcomers in the United States. Following the presentation by both our presenters, we'll have a brief Q&A session. You may submit questions by using the Q&A function in Zoom. And for those of you who are interested in receiving continuing medical education credits, please be sure to log on before the session starts. The information is here. You can use the QR code, and also the information will be in the chat so that you can refer back if you're having trouble or you need additional time to log in to receive credit for this session. There are several other opportunities for students and the public. There are micro-credentials and badges that are available. The Public Health Lecture Series has a digital badge program if you're interested in receiving those badges for previous speaking sessions or this current session. We also have the Health Equity and Criminal Justice micro-credential and the Public Health Workforce Skills micro-credential. And the links to that will also be in the chat. And then finally, I'd like to invite you all to listen to our podcast, Public Health Perspectives for Change, where you can listen to additional information about the sessions with our speakers. We go more in depth on issues that were covered during the session. You can listen to speakers from the last 3 years, and there's some quite intriguing conversations that we're having. So now I'd like to introduce our panel speakers. Our first speaker is Dr. Tina Sachs. She is an associate professor at the University of California's School of Social Welfare. Her field of interest include racial inequities in health, social determinants of health, poverty, and inequality. Professor Sachs focuses on how macro structural forces, including structural discrimination and immigration, affect women's health. Her current work, funded by the Russell Sage Foundation, investigates the persistence of racial and gender discrimination in healthcare settings among racial and ethnic minorities who are not poor. Her book on Black women's experiences in the healthcare sector, Invisible Visits, Black middle-class women in the American healthcare system, received an honorable mention for Best Book of 2020 by the Society for Social Work Research. Please join me in welcoming Dr. Sachs. I'd also like to introduce Dr. Maria-Elena Young. She is an immigrant health scholar whose research seeks to understand the impact of the U.S. immigration system on the well-being of immigrants and their families. She has established new frameworks and measures to understand the relationships between immigration policies, citizenship, legal status, and health, and has conducted some of the first empirical studies showing that immigration policy is associated with health inequities. A guiding principle in her work is to partner with immigrants and community members as active contributors in the design and interpretation of research. Both these panelists will bring unique perspectives and timely perspectives as we all navigate the policies and environment today. So I'd like to welcome Dr. Sachs to begin her presentation.
Good evening, everyone. Thank you so much for the invitation, the opportunity to speak with you this evening and to be in community with you all. The title of my talk is Cultivating Health and Hopefulness in Uncertain Times. And I would imagine that we can agree that these are challenging times that we are living in right now. The agenda for my talk is I want to do a few things tonight to make three sort of main points. One thing I want to put forth is a theoretical framework that really helps us think about, or I hope helps us to think about and to put into place something that pushes a little bit beyond the idea of social determinants, but encompasses social determinants to help us think about the structure of society. So thinking about the built environment, the institutions like healthcare, education, criminal legal systems, et cetera. And to think about how that is also related to structural violence. So, structural violence is a concept that has been put forth by anthropologists, also medical providers, Paul Farmer, among others. And it really helps to provide a kind of a political lens on the social world in which we live. Then I will just go through some descriptive data, a snapshot of California, who lives here, who are our neighbors, who are the people that we are in community with every day. And then I'll talk a little bit about sort of put that into perspective, relative to the United States, and then provide a little bit of data about California and the health of our fellow Californians. And then finally, what I want to do is help us think about what we might be able to do to mitigate some of the health inequities that I'm going to present. And we can do that, I would argue, in a couple of different dimensions, one of which, of course, are policy interventions, such as addressing the social safety net, the healthcare safety net, et cetera. But given the uncertainty of the times, I would argue that another thing that we must attend to is actually caring for one another. And to present to one another what it looks like to live and be in community with one another, and to perhaps lean into interventions like mutual aid and community care. And as Cornel West often describes, to try to think about what love looks like in public, which he says is justice. Justice is what love looks like in public. So the idea of structural violence really encompasses the idea that excess morbidity and mortality, health, differences between racial groups and other axes of difference are not inevitable. They're not natural, and they are not equitable, but they really are the biological reflection or manifestation of social inequality. Okay. And so this idea is really sort of pushing us to think about who are the actors here. So it's not just that the society is arranged in a certain way, but who arranged it in that way and who benefits from who benefits and who is harmed by those particular arrangements. So we typically hear about social determinants in social epi and medical sociology, among other social sciences, which really thinks about the causal relationship between inequality and deprivation and health outcomes. But the idea of structural violence is one that really highlights and leans into the concept of the violence of hierarchical power structures in the creation and reproduction of inequality. And it seeks to name these structures more directly. And then the idea is, in so doing, once we name these axes of power and the holders of power, that we then may be able to do something to intervene to facilitate a more equitable distribution of power and resources in society. And so these are really, politically potent concepts. And so I want to just acknowledge that that is front and center in this work. And I think at a time in which we are concerned about the way language is used, the way misinformation is spread, that this is a way that we can really think about how is the sort of prevailing political order maintaining or dismantling the status quo, and in what ways, right? So that we can have an analysis of power that informs what is public health. For some reason, my slides just froze. Let me see. Okay, there we go. So that's the sort of the orientation, the framework that I want to provide for us here. And now I'll shift gears and move into just describing who lives in the United States with us, right? Who are our neighbors? And we're hearing obviously right now so much about people who are undocumented, our immigrant friends and neighbors who are in the United States without the legal authorization to be here. And what we know roughly is that there are about 13.7 million people in the US without this legal representation, legal authorization, I should say. There are also 14 million US citizens, lawful permanent residents, or temporary visa holders here who share a household with an unauthorized immigrant. And so the point of demonstrating or just simply stating this is to really state the obvious, is the imbrication, the mixing of people who have legal status with people who do not. And what that means for family structure, for family life, for community life, and the kinds of threats that people are under when a member of their household may be here in the US without proper authorization. It essentially, I would argue, puts everyone in that household at risk of some sort of state-sponsored violence. Also, about 4.2 million unauthorized immigrants are married to a US citizen or a green card holder. And when we're thinking here about children too, about over 6 million children under the age of 18 live with at least one unauthorized immigrant parent, and 5.3 million of those children are US citizens. And so that means that at least 5.3 million children in the US are under threat of having one of their parents deported. And so we know obviously that the kind of strain and incredible trauma and harm that can cause, even if it doesn't necessarily happen, but the threat of it happening is a certain kind, a particular kind of violence. Also, the people with Mexican citizenship are about 40%, represent about 40% of the unauthorized immigrants in the United States. And that's down from about 62% based on 2010 data. So this is just a pie graph that illustrates the origins of people who are in the United States, the top countries for unauthorized immigrants in the U.S. And you can see that people come from all over the world. There are many push factors. I'm not specifically a scholar of immigration, and political systems in other countries, but I know there are many reasons that people feel that they need to leave their country of origin and make this incredibly, oftentimes dangerous, lonely, treacherous journey to begin a new life in the United States. And so you can see here that about 70%, almost 70% of immigrants in the US that are unauthorized are coming from Mexico and Central America, but there are also immigrants from the Caribbean, South America, Europe, and Canada. I am actually from Chicago originally, and Chicago has had at one point the largest Polish population outside of Poland, and many Polish immigrants are actually undocumented. And so you can see here, though, that as you're thinking about the ways that immigration is racialized and the discourse around immigration is racialized, that we don't often think about white people as being immigrants, but they absolutely are. There are also about 4.3 million Black immigrants in the United States. And so that's also not the face of immigration that we typically think about. Obviously, the data suggests that the majority obviously are from Mexico and Central America based on these data. But this is just to illustrate that people are coming to the United States from all over the world and have many reasons for that. There are many reasons for them to make this journey. This is just a chart that also shows similarly the different origins and the estimates of where people come from. And so you can see here that the sort of the distribution is relatively similar to the pie graph that I was just referring to. But I did want to make this point, especially as we're thinking about information or misinformation, that this table shows immigrants who are coming from sub-Saharan Africa. And so this is what this illustrates is actually the increase over the years of people who are coming from sub-Saharan Africa and represent about 2.5 million people in the United States as of 2024. And that there are, given the history and present of anti-Blackness in the United States, that we don't hear very much. But sort of Black immigrants are often an invisibilized group of people who are impacted by the challenges that immigrants face, and also the nexus there of the vulnerability that immigrants face with anti-Blackness in particular. So now moving to the state of California. California obviously is an incredibly large state. It's an incredibly diverse state. It's home to almost 11 million immigrants, and that is 22% of the foreign-born population of the entire country. In 2023, about 27% of the state's population was foreign-born. Almost half of all children in California have at least one immigrant parent. And at least a third of people in this particular age group, this prime working age adult age group, 25 to 54, are foreign born. So this is a country that is this is a state in which immigrants are certainly driving a lot of the economy, working, especially in the American metrics as we think about contributing and productivity. This is certainly not a group of people that is not contributing in the sort of standard economic ways that we think about. More than half of California's immigrants were naturalized U.S. citizens in 2023. And, excuse me, sorry about that. And this is, they're actually, the number of undocumented immigrants in California is actually down by about 1 million people from 2007 to 2022. And in 2022, the overwhelming majority of immigrants were either citizens or had some sort of other legal residency status. One thing I want to really make very clear, though, here is that the share of immigrants in California has stabilized in recent decades, and also the share of immigrants of the total population of California is relatively high, and you can see from this bar graph that California dwarfs the rest of the United States in terms of the percentage of the population that is an immigrant or foreign born. And so I think that gives California some very particular, perhaps, responsibilities and challenges and also opportunities to really innovate and think about how we treat our immigrant neighbors and how we engage with and how we, how immigrants are profoundly without immigrants. Obviously, it's a trope, but I think it's really true. Without immigrants, the state of California certainly would not be would not be producing as much in terms of GDP and all of these other metrics of economic productivity that we typically rely on. Another thing I want to point out that may be surprising to people is that people from Asia are the leading source of recent immigrants to California and have been for many, many years. And so, again, because of the discourse or the narrative that is typically put forth about all immigrants being Latina or Spanish speaking, we know that that's empirically not true. And so the California obviously has a lot of people, there are a lot of Asian immigrants in California. I did see some data also that suggested that Asian immigrants are also among the fastest growing group of undocumented immigrants in California as well. And so that's another thing as we're thinking about supports and how we might provide services or other community supports and protections to people that we want to be thinking about are immigrants from all over the world, not just from Latin America or Spanish-speaking countries. So just want to shift gears here just a little bit, and I will not belabor this too much, but I wanted to take us through some data about health. And so I gave this snapshot about the immigrants in California who who our neighbors are, who we are. And I just wanted to take us through just a little bit more about some the health implications of the snapshot of what it is like to the health snapshot of California. And so first, obviously, as we're thinking about health, one always has to consider poverty and access to socioeconomic resources. And so you can see here in these pie charts that typically, you can see the population by race. Obviously, California is a huge state with almost 40 million people. And you can see the breakdown here in terms of the racial groups here. So about in 2020, about 39% Latinx, 38% white, 18% Asian, and 6% Black, and then some other, American Indian, Alaska Native, and Native Hawaiian Pacific Islander groups as well. Then thinking about the population of the state of California, here's some data that demonstrate the poverty rates, how many people are living in, not how many, but the proportion of people who are living at the federal poverty level. And so here you can see the racial disproportionality of people who are living in California based on race, such that Black Latinx communities are much more likely to be living in poverty, even all the way up to about 299% of poverty. And so this is something that I think that we are all well aware of, but certainly poverty and not having enough socioeconomic resources are this is closely related to health inequity. And also, to bring it back to the opening framework that I presented, it also, to my mind, is a form of structural violence, because living in poverty is violent. Not having enough food, not knowing if you're going to be evicted, not knowing if you have a place to sleep, or if you're going to be able to ensure that your children can get to school, because perhaps you don't have transportation to be able to get them there. You don't have money for the bus or the gas for the car. This is a kind of violence that is really invisibilized, but it is also a form of structural vulnerability that I hope that we can also make more plain, make more visible. You can see here that, again, across almost all measures here, you're going to see racial disproportionality in many health outcomes, many measures. So you can see here that Black people in the state of California die younger than other groups, but that others have Asian Americans and Latinx communities also have a longer than average lifespan. And so what we're hoping, obviously, is that everybody would have the same access to a long life with their family and loved ones. And so hopefully that these sort of structural interventions that I'm going to talk about may be able to mitigate that or may be able to lead to that. These are, again, more data that sort of illustrate very similar patterns. Okay, so these are preventable hospitalizations by race and ethnicity, where you can see that across a range of health outcomes, heart problems, asthma, COPD, heart failure, diabetes, etc., you can see the racial disproportionality such that in this case, Black people are much more likely to suffer from these preventable hospitalizations. And I also just want to, and also Latinx communities as well. And so obviously, as we're thinking about these, when we're talking about race and ethnicity, these are large, aggregated data set. So we don't know if these people are necessarily are immigrants or not, but it's always given the population of the state of California, one might be able to think that there might be a substantial number of immigrants that are included or reflected in these data. You can see here again, hospital readmissions by race and ethnicity. That there's a lot of racial disproportionality here as well. I'm just trying to be mindful of time, so I'm going to just show these here and I wanted to just provide this kind of flavor for us that in some instances, Latinx communities fare well, thank goodness, in terms of health inequities. But we know that for many ethno-racial groups that the health inequities persist across different categories, including cancer early diagnosis, cancer death, etc. Maternal health, obviously, one of the most a measure that has proven to be relatively difficult to move, again, is a sort of preterm birth that Black people who are giving birth are more likely to have preterm births and less likely to get prenatal care, although there's a little bit of variation there by race. Infant health outcomes, this is the same story. Unfortunately, we observe over and over in the data, low birth weight and infant mortality also overwhelmingly disproportionately impacts Black people and Black babies. And of course, Black maternal deaths. Black people are overwhelmingly more likely to die in the first 42 days after delivering a baby compared to other racial groups. And then moving into homelessness, one of my dear colleagues, Professor Jamie Chang at UC Berkeley, has been a real pioneer in the study of homelessness, particularly in California, and particularly as it impacts actually Asian Americans and Native Hawaiians and Pacific Islanders in California, looking also at mortality among these groups, people who are dying on the streets of California. And so this is something that I just think is really important given sadly in California, the disproportionality of our homeless, houseless population here. And then you can see here that Black people, again, are overwhelmingly represented among homeless people in California, although Black people represent a relatively small proportion of the population of the state of California. And we know people of late have been seeking more, there's been an increase in people who've been seeking services for homelessness. We know that many of the people, at least, almost 50% of people in a particular sample of houseless individuals reported a disabling condition. So we're having, obviously, living on the street is disabling in and of itself. But we are seeing our most vulnerable people living on the streets with significant mental, physical, and emotional impairment. And then we also have a fair number, tragically, of children who are living on the street and who are houseless. And there are obviously different definitions of homelessness. Some people are sort of surfing, they don't have stable housing, but they may not be living outside. They might be in congregate housing, et cetera. But this is really just a snapshot of our communities. So coming to wrap this up relatively quickly so that we can move on to Dr. Young, I always want to try to think about all of these data, these relatively intractable, or what we have seen thus far as being difficult to move, racial disproportionality, poverty, vulnerabilities across multiple dimensions. And so, what can we do about this? And so, I think we really have to think about the fact that this is not natural. This is not necessarily something, this is not just an act of God. That this is really about how we have allocated our resources in society and how much injustice we are willing to tolerate, and particularly if we are if we are a member of the community that is being harmed, or if we are a group that potentially benefits from the status quo. And so I want us to really try to grapple with that and hold some of those uncomfortable tensions around. We all benefit from the way society is arranged in certain ways because we have varying levels of privilege and vulnerability. But we really, I would argue, one of the ways that we can move forward as a society is to think about those of us who are sort of the most vulnerable among us, and to try to arrange a society that would do no harm to the most vulnerable among us. And so this is, I know that some of you on the line are practitioners, whether that's, public health practitioners, physicians, et cetera. So I wanted to put forth this idea, this concept of structural vulnerability, which is related to structural violence. But this is a checklist, kind of a heuristic that was developed by a colleague, Bourgeois, and another colleague of mine at Berkeley, Dr. Seth Holmes, to really try to think about orienting the clinical encounter toward the structure that the patient is embedded in, to try to minimize blaming the person for their health outcomes, blaming the individual for their health outcomes. Obviously, there's free will. People do make decisions on their own, but they are bound by the kind of structure that they are embedded in, I would argue. And this structural vulnerability tool really helps to reorient the clinical encounter to take these structural vulnerabilities into account. This is a structural vulnerability checklist that one might be able to use in a clinical encounter. And this is really just trying to get a sense of whether the person has what they need. Do you have enough money? Do you have resources? Do you have somewhere to live? Do you have food? Do you have anyone that you can lean on? Do you have social support? And so obviously during a 10-minute encounter with a physician or other healthcare provider, you're not going to be able to necessarily intervene on these multiple complex factors, right? But I would argue, and I think my colleagues would also argue, that just having this sort of orientation to the structure can help you understand and make sense of the person's behavior, their health challenges, and also the resources that they do have, right? That might be able to help you help them. So coming to the end of my presentation here, I want to always again reorient us to the structure of society and the fact that many of the challenges that we have they're sort of rooted in this idea that we have limited resources. We don't have enough money to do what we need to do. We certainly we can't provide enough food for people. It's too expensive. We don't have enough resources. And I would argue that that sort of scarcity mindset in the largest economy in the world is a choice. It is not a fact. It is a decision that we make about who deserves their basic needs met, and who does not. And so, given that these are policy choices that are being made, there are also policy interventions that can be done to intervene and disrupt this kind of structural violence. And so we see these examples all the time. During the pandemic, we saw that we could have stimulus checks, we could extend unemployment benefits, we could put a moratorium on evictions. And oh my goodness, all of a sudden we had a decline in poverty rates and a massive reduction in child poverty. And so all of these things, particularly given the composition of the state of California, we know who is going to be most vulnerable to not having SNAP benefits, as we are currently experiencing right now. We know that children of immigrants are going to be multi-marginalized in this kind of society. But there are things that we can do to mitigate that. And I would argue we have a moral responsibility to do so. These are just some examples here of of organizations that have sprung up in the spirit of self-determination to provide resources to people who really need health care, who need companionship. This is a guaranteed income program that's being done right now in the state of California to help pregnant people. And so just to close here, I want to say that I think what is required is really is to really think about repair, and to use universal and targeted approaches to expand the social safety net. Obviously, I am not naive to think that in the current moment that we're going to have expansion of the social safety net. But I still think we have to imagine the world we want, and that we can also, during these times, lean into what it means to rely on one another. We don't need to rely on charity, quote unquote. We can rely on one another in a situation of mutual aid in which we are deeply in community with each other. And so finally, the last thing I just want to say is that in difficult times, I'm calling this an effective intervention. And what I really mean here is that care and love is important. It matters. And one of my favorite thinkers and activists, Mariam Kaba, says hope is a discipline. And that is one of the things that I want to hold on to and leave you with in this moment. It doesn't mean that we're not frustrated or sad, but that there's always, as Mariam Kaba notes here, I believe that there's always a potential for transformation and for change. And that is in any direction, good or bad. And so I just invite us all to lean into what I hope is holding on to hope and making this transformational change for the better. Thank you so much.
Thank you so much, Dr. Sachs. I really appreciate it. This is a great start, and it really is going to ground us for our next presentation. I'd like to invite Dr. Young to share her presentation. and then we'll have Q&A at the end of Dr. Young's presentation.
Wonderful.
And before Dr. Young jumps up, I just want to appreciate the community for chiming in as we were listening to Dr. Sachs's so many nuggets that seem to resonate with people. So thank you so much, and let's continue to engage as we hear, from these brilliant thinkers and be a part of the conversation. So thank you.
Great, thank you. Thank you so much, Dr. Sachs, for setting that stage. It's really wonderful to be with all of you online this evening. Calling in here from Merced, the Central Valley. I was born and raised in Oakland, so love to see so many. I saw a bunch of Oakland folks on the line today and folks from all over California. So it's really wonderful to have a chance to share with you. In my presentation today, I'm going to be talking about immigration policy specifically and looking at it as a social determinant of health, as an example of one of those social determinants that Dr. Sachs set up for us. I'm going to first talk a little bit about what is immigration policy, and give you some frameworks for sort of thinking about what are the different examples of immigration policy that we see shaping our day-to-day lives, regardless of whether or not we're immigrants. And then I will shift over to sharing some data I have from some studies where we tried to get a look with across the state of California, sort of population estimates of how immigration policy is touching the day-to-day lives of Latino and Asian populations in our state. So just to start, sort of what is immigration policy? I loved what Dr. Sachs was sort of emphasizing, that these are intentional decisions. Sort of the inequities we see in society are choices that are made by society. And immigration policy is a perfect example of that. Immigration policies are laws and policies that essentially are choices made by people in power to determine who can enter the country, the terms of their possible removal, so deportation, but also what the kind of rights and protections they're granted as non-citizens as they settle in the United States. Immigration policies can take all sorts of different forms. So we often think of immigration policy as something that's happened at the federal level. Very recently, of course, under the current administration, we've seen executive orders coming down, but immigration policy really takes a lot of different forms. It can be legislation at federal or state levels. It can also be local ordinances. Your local board of supervisors in your county can essentially enact forms of policy that are immigration policy. It can also be regulations. State agencies like the DMV, for example, are involved in sort of shaping the contours of immigration policy. And it can also be court rulings, things coming down from the Supreme Court. So in all, what immigration policy is essentially sort of the power that federal, state, and local governments have to determine the social position of people who are foreign-born, who are non-citizens, who are making their lives here in the United States. And I really want to emphasize kind of along this point that immigration policy is intentional. Immigration policy is recognized as being a mechanism of structural racism. It has been used historically, dating back to some of the earliest immigration policies in the late 19th century that barred migration from immigrants from China. It has been intentionally used as a tool to shape the racial composition of our country and to shape a subordinate racial position for different immigrant groups, primarily non-European immigrant groups. And so when I talk about immigration policy, I sort of like to set up sort of two ways of thinking about the different types of policies that exist. So on the one hand, we have inclusionary immigration policies. These are the policies that extend across multiple different public policy sectors that extend rights, protections, and eligibility to non-citizens. And all of us in the health field, we see these each and every day. So for example, a key example is federal and state Medicaid policy. Right? You might think, oh, is that really immigration policy? It's health policy. Well, in those policies are explicit prohibitions or inclusion of non-citizens. So for example, at the federal level, Medicaid explicitly bars people who are undocumented and lawfully residing individuals who've been here for less than 5 years. In states like California, we expand Medicaid or Medi-Cal here in California to include people who are undocumented or who have a temporary status or who have been here for less than 5 years. Other areas of inclusionary policy include education policy, such as giving undocumented students the ability to pay in-state tuition in states, labor protections, and in industries such as agriculture, where there's many immigrants, or in domestic work. These are all policies that shape the sort of rights and protections that immigrants have. And also kind of driver's licenses. So in California, for example, you can receive a driver's license regardless of your legal status. So these are all areas of policy that are shaping the ability for non-citizens to have societal inclusion and have opportunities. On the other side, though, we have what I call criminalizing policies. And these are policies that authorize surveillance, policing, and potentially ultimately deportation of non-citizens. Now, a lot of these policies are federal in nature. Only the federal government can determine who is deported. But we also see a lot of state and local policies that end up intersecting with those federal policies. So, for example, in some states, it's authorized for local law enforcement to collaborate with ICE. In California, that's prohibited under our state law. But you also see things like traffic stops and racial profiling, which are local policies intersecting with and putting people at risk for in contact with the immigration enforcement system. So across the United States, we have not only federal policy, but at the state level, states kind of weighing in and making decisions about the extent to which they are going to criminalize or include their non-citizen populations. So I have for you here a map that illustrates across the US the policy contexts that people are living in. In the yellow, you see states that have many criminalization policies and very few inclusionary policies. In contrast, in the blue, you see states like California that have very few criminalizing policies. So to a certain extent, our policymakers have chosen not to criminalize immigrants, and many inclusionary policies. I'm happy to talk about this more in the Q&A, but there's a mounting body of research that really essentially shows that in states that have many criminalizing policies, you see that there's worse healthcare access. Or in a state like California, fewer criminalizing policies are associated with better healthcare access. So simply just sort of being in a state where policymakers have opted for inclusion over criminalization is better for healthcare access. And indeed, in a state like California, we have typically been pretty pro-immigrant. That, however, is not the end of the story. In some of the qualitative research that I've done here across the state of California, what we regularly hear is that despite the state level, our state sort of having these inclusionary policies and trying to not criminalize immigrant populations, there's a great deal of variation. So I want to share with you a quote from a study I did, a participant, and let me just read this to you. When you're an immigrant and you're residing in a sanctuary state, that's a state like California, the policy probably allows you to sleep a little better at night, but it doesn't change your daily life. You're still going to get pulled over if somebody wants you to be pulled over. You're still going to be frowned upon when you walk into a grocery store with dirty clothes from working in the fields. Immigration policy is not only made at the state level, the federal level, the state level, it's also made at the local level. So in some of my research, I've sought to sort of try to understand what's happening at the local level. So I'm sharing with you now maps that my research team has produced that describe the different policy contexts across California counties. So again, remember on the big national map, California is much more inclusive of immigrants than a state like Georgia or Texas was. However, once we sort of quantify what's happening at county levels, what types of policies local school boards or boards of supervisors are enacting, and patterns of the very indicators that Dr. Sachs was just sharing with us, poverty, educational attainment, health outcomes, we see a clear picture that those inequities, sort of those tensions between inclusion of immigrants and criminalization of immigrants replicate themselves even within our state. So on this map here on the left is mapping just purely the number of inclusive policies that we have in the counties across California, and green counties are more inclusive. I've circled there in the middle Merced County because we actually have quite a few inclusive policies. On the right side, though, we've mapped social inequality, those same indicators, poverty, incarceration rates, educational levels that are linked to immigration policy. And the counties that are red are more inequitable. I've circled for you Merced County in the middle. You can see that even across different axes of how we measure and think about immigration policy, we see differences. So Merced County has a lot of policies on the books, but we see indications of quite a high level of social inequality. So these sort of differences and tensions really point to the need to understand what is actually happening for people residing in these policy contexts. So I'll just share one more quote with you from one of my studies. This is from somebody in the San Joaquin Valley from a legal aid organization. They say, "The San Joaquin Valley is very conservative, so a lot of our fights are just against that, a conservative anti-immigrant mentality at the Board of Supervisors and city councils." So even in a state that is a sort of ostensibly pro-immigrant, we see variation within the states and across counties. So my research over the years has really tried to sort of disentangle what's actually happening on the ground for immigrant communities. We sort of know at the national level, there's kind of an increasingly anti-immigrant policy slant. At the state levels, we see very different state policy contexts, but then even at county levels, we see very different immigration policy contexts. So sort of what's happening between those policy contexts and people's actual health status and healthcare access. And so sort of thinking about that framework of inclusionary policies that criminalize or inclusionary policies that include people, my research has sought to understand sort of what are immigrants' actual experiences of policy on the ground living in California. So I'm going to turn now to sharing data with you from two different studies. I'll start with the RIGHTS study, which is the Research on Immigrant Health and State Policy study. This is a population-based survey that I conducted with colleagues at UCLA. We interviewed adults who were foreign-born from any country in Asia or in Latin America. So there's two continents, and sort of broadly calling them Asian and Latino immigrants. Very heterogeneous group, so happy to sort of talk about the challenges around racial categorization of immigrants. But we wanted to just see across these two immigrant groups, very diverse, as Dr. Sachs has already talked about, sort of what are we seeing in terms of how they are actually living immigration policy. And then the second study, which is the policies influencing rural Latino health, I wanted to go in depth into one specific immigrant demographic group and not just look at foreign-born populations, but also look at US-born populations within that racial ethnic group to sort of see how immigration policy is shaping their overall racialization, their experience of living under these policies, and then potentially their health. So in both studies, I developed survey measures, which I'll show you in a moment, and fielded these through phone calls and internet-based survey methods to obtain representative samples of individuals living here in California. So let me start with the RIGHTS study. We asked a series of questions to understand how people had actually lived immigration policy. So what I'm going to do is just jump right into the data, and by doing that, sort of share with you a little bit about the types of questions that we asked. So in this first chart here, all the charts are similarly set up. Across the bottom are the survey questions that we asked. So we, for example, one of the questions you see on the left here is we asked people, were you ever denied public benefits due to your income? And people were asked simply to respond yes or no. And so they, it's just very kind of straightforward. Is this an experience that you have ever had in your life? And this was asked of Latino or Asian immigrant adults. And then along the y-axis, we have the percent of respondents who answered yes, that this had actually happened to them. So I first share with you questions that had to do with experiences in the health and social services sector. And I want to just highlight a couple of these for you. And I'll give you all a moment to sort of look at look at these numbers. One of the key questions we asked was, as we asked people if they had ever avoided government programs out of concern that it could affect their immigration status or the immigration status of a family member. And so this refers to a federal policy called public charge, which essentially renders people inadmissible for a green card if they ever use public benefits. And what we found was 1 in 4 Latino or Asian immigrants in the state of California had at some point opted not to use public benefits because they were worried of the implications for their immigration status. And this is really, really quite high, quite astounding. The next set of questions we asked was ask people about experiences in their workplace, sort of labor and employment exclusions that they may have experienced. So again, across the bottom are the different types of questions that we asked people. So, asked a lot of questions around like, were they ever, potentially experiencing their work authorization expiring? Had they ever experienced wage theft? Were they ever barred from a job because of their legal status? And just to highlight a couple of key points here, we found that, the arrow is actually in the wrong direction here, but on the left there, you see that 1 in 3 respondents had ever experienced being barred from a job because of their legal status. And I think this really speaks back to sort of the issues around economic opportunity and immigrant workers, right? This is really high. The 1 in 3 Latino or Asian adults in California have been unable to pursue a job because of their legal status. The other point I want to highlight here is that 1 in 4 reported ever having experienced wage theft. So despite protections against wage theft, research indicates that people, particularly who are undocumented, but immigrants more generally, often feel that they are structurally vulnerable when it comes to speaking up in the workplace. And so they are very much vulnerable to wage theft. And indeed, we see here in these data, 1 in 4 were denied wages, were robbed of their pay. And then finally, we have a set of questions that we ask people directly about their contact with the immigration and law enforcement system. And happy to talk about this during the Q&A, but we actually formulated the questions really sort of melding together immigration enforcement, which you might think of more as DHS or ICE, with law enforcement and local police because of the links between the two. And also sometimes people don't necessarily know, is this police or is this ICE? And so a lot of the questions were really around sort of policing generally. Again, across the bottom are all the questions that we asked, and we simply asked people to report if this had ever happened to them. So a couple of things I want to highlight from these data are, first of all, on the right there, you see 1 in 3 individuals reported knowing somebody who had been deported. So when we talk about people's sort of fears, or there being fear in community, I always really want to emphasize that this is not a theoretical or hypothetical fear. For large proportions of the immigrant population in California, this is already something that has hit close to home. Could be a family member, it could be a more distant acquaintance, but it's within people's own network. 1 in 3 people knew someone who was deported. And then sort of thinking not as severe as deportation, but again, sort of this reminder of a racially subordinate status within our immigration policies, 1 in 8 respondents reported that they had ever been racially profiled by the police. And so again, not necessarily something that resulted in an arrest, but a sense that they had been unfairly targeted by police because of their race or ethnicity. So that sort of gives you sort of overall a picture of just the extent to which Latino and Asian immigrants in California have had contact with the immigration system. So I did this study with colleagues at UCLA from 2018 to 2020. And in exploring the data, a couple of things came out. One was that most of the data on immigrant populations comes from urban communities. And, for a reason, right? Los Angeles, for example, is a large city. The Bay Area is a large city. But if you look at the demographic trends, immigrants are increasingly helping to populate rural areas across the United States. And particularly in states like California, because of agriculture, particularly Latino immigrants, but also Filipino, Indian, other South Asian groups have long been immigrant communities to rural parts of our own state. And so to sort of fill that gap, my most recent study is the PEARL study, the Policies Influencing Rural Latino Health. And using very similar methodology as the RIGHT study, we conducted a population-based sample, this time of Latino, foreign-born, and US-born respondents in rural communities in both California and Arizona. And in this study, I won't have data on this tonight because we're still actually just analyzing all of this, but we want to be able to compare two states because of what we see, right? Again, it's with such different policy contexts across states. So I want to share with you the survey data and then get a little bit into some of our analyses showing the links between these policy experiences and health outcomes. So the PEARL study is somewhat similar to the RIGHT study, but what was unique was that we wanted to develop a whole new set of questions. In doing interviews with community members, what became very clear is that it's not only that immigration policy leads to these very concrete consequences of racial profiling, deportation, wage theft. Before even getting to that point, people are contending on a day-to-day basis with complex institutions, agencies, bureaucracies. I suspect a lot of you in the health field have seen this with your own clients and patients who are trying to figure out how to get interpretation, how to complete paperwork. So for this study, we developed a whole new set of questions that I present here on this slide that really tried to get at the concept of navigating policies, not just sort of contending, kind of confronting the exclusions and the harms of policies, but also the day-to-day stressors, burdens, and I would say structural violence of having to navigate the complexities of systems that are produced intentionally to exclude immigrants. So similar to the last setup, across the bottom here are each of the questions that we asked, and I apologize, more questions here. We're trying to squeeze in a little bit more here. But I'm going to highlight for you a couple of the measures that we have. One second, if I can get this to. So a lot of these measures were really, again, about obtaining information, how difficult it was to obtain information, and then figuring out how to make decisions about using care or obtaining services, and then kind of having to use your networks to actually obtain services. So I want to highlight on the left here in the dotted box here, 1 in 5 respondents reported that they had ever struggled to apply for or pay for immigration benefits, right? And I think this speaks right to the heart of two things, sort of the intersections of poverty and limited economic opportunities, but also policy decisions that make it expensive for people to naturalize, to apply for a green card. And so you see a very high burden from just the cost of navigating the immigration system. And then the second box there, we have 2 in 3 respondents did not know where they could find legal aid. And so in a very complex immigration system, the majority of individuals reported not knowing at the moment at where they would be able to go to seek help should they need it. And then we also see that because of these challenges, a very high proportion of people reported helping out others in some way to navigate complex systems produced by immigration policies. So 1 in 2 respondents, it's half of all Latinos living in these rural communities, had ever had to help another person navigate care. So not just worrying about their own, but also helping out others. And then 2 in 5 reported having served as interpreters for family or friends. And I'm sure for those of you working in clinical contexts, that will come as no surprise. But I think it's important to put it in the context of sort of an exclusion created by immigration policies and sort of a failure of investing in and making language accessibility a reality. And then we asked a similar set of questions that had been asked in the rights study, sort of around, again, these direct consequences. So for example, in this particular sample, we asked about racial profiling, and 1 in 5 had ever been racially profiled, and 1 in 3 knew someone who was deported. And so just to wrap up for this study, what I want to share with you now is our statistical test to sort of see what is the relationship between these experiences. It's very clear from the data that there are widespread exclusionary experiences with immigration policy. What is the impact of having lived those experiences, of having lived that exclusion on one's access to care? So we conducted regression models, testing as just a simple count, literally the number of navigating experiences that a person had had and the number of encountering experiences that they had had. And we looked at, is there an association with barriers to healthcare? And here is our here are our results. And these are somewhat preliminary. We're just starting to get into the analysis. So excited to answer questions and keep an eye out in the future for some papers on this. So it really surprisingly, we found that regardless of how much people have had to navigate immigration policy, this was not associated with whether or not they had a usual source of care, meaning people had a usual source of care regardless of exclusionary experiences with the immigration system. That, however, very quickly changed when we started looking at how frequently people were actually using that care that they had. We see a very clear pattern in this chart. Along the x-axis is just simply the total number of navigation experiences that people reported having. And then along the y-axis is the probability, kind of just what are the chances that they had not seen their primary care provider in the last year. And what we see is a very clear trend. As that number of navigation experiences go up, we see the probability of having seen your primary care provider in the last year go down. So a very clear relationship. That burden of navigating is directly associated with the chances of just not going to get care from your primary care provider. We see a similar pattern with having delayed needed care. We looked at, again, the number of times people had to navigate immigration policy, and what we see is that a very clear upward pattern for each additional experience navigating immigration policy, there was a higher chance that that person had delayed their needed healthcare in the last year. And we see very similar patterns with the encounter measures, which I'll go through pretty quickly. Again, having encountered immigration policy was not associated with having a usual source of care, and I'll talk about that in a moment. Interestingly, having encountered immigration policy was not associated with having seen a primary care provider, but having those encounters, having been racially profiled, knowing somebody who was deported, having been asked to prove your citizenship status in a healthcare setting, each additional one of those exclusionary experiences was associated with the higher probability of not having gotten the healthcare that you need. Okay, so to kind of wrap up so we can get into the questions here, sort of what does this all tell us? So first of all, just sort of looking at the descriptive data, it's very clear that Latino and Asian populations in California have had extensive experiences with the consequences of immigration policy. And I really like to sort of emphasize again, it's that yes, people are fearful, people are avoiding certain spaces or places because they're worried, but that worry is not theoretical. It is based on the lived experiences of themselves or of family members. These are direct, very material consequences in people's lives. And my message always to those who are working in clinical settings is that spaces that are clinical spaces are not just places that need to be safe, that dispel fears. They need to be places that are helping people process and respond to these exclusionary and really, I would say, traumatic experiences. The second piece is there is some good news in these data. Even people who had very exclusionary experiences were still had a usual source of care. And what I think this really speaks to is the importance of established and trusted relationships with providers. I would like to test this more myself, but I think that once people have a connection with a provider, negative experiences aren't going to necessarily fray that relationship. And I think this is the positive news in these data. That said, there's also a clear evidence in these data that even if they have a usual source of care, the burden of having to navigate immigration policy, the harms of having to encounter these direct exclusionary consequences really leads people to be less likely to get the care that they need, whether it's regular checkups with their PCP or delaying more urgent needed care. And I think that this is likely more than just issues of trust. We have to look at things like the financial burdens. If you have experienced wage theft, are you potentially going to delay care? Potentially, yes, because you've literally lost money, right? If you have had the burden of translating for your own parents multiple times when they need care, you might put your own care on the back burner. So there's a lot of dynamics here, but I think thinking about how the burdens of the immigration system essentially make it so that people cannot prioritize getting their own care is a really important takeaway from these data. So I think I'm going to leave it at that. I will have my last little plug here. I'll put this in the chat, but next week I'm part of a webinar where we're going to be talking about the impact of these types of policies on the long-term care workforce and sort of how this affects people who are working with aging populations specifically. So look forward to the questions. Thank you all so much.
Thank you so much, Dr. Young. We really appreciate the thorough and all of the detailed information you're providing about what's happening right here in Northern California. I can say that I was very surprised to see the gap between the policies and then the social inequities that were occurring. And I think that there is a huge disconnect often between what's really happening on the ground and the policies we put in place. So I think that's really important for us all to keep in mind. I'd like to remind you all to please put your questions in the Q&A for Dr. Sachs and Dr. Young, and we'll fill the questions as they come. Let's see. We have the first one. The first question is, as a newly trained professional and a US-born member of a historically disadvantaged racial group in California, I struggled to secure work, and many workplaces appear to hire almost exclusively within tight cultural or immigrant networks, leaving qualified US-born applicants excluded despite qualifications. How can policies ensure fair hiring? And so, I think this is a common question or feeling that many people have, that they feel at least this has been promoted within our media. And I think it's worthy of us really addressing, what is really happening.
I can speak to that, and I really appreciate the question and sharing about this person sharing their own experiences. I mean, I think overall there's very clear evidence that immigrants do not take away jobs from US-born workers. So sort of at the national level, kind of at the aggregate level, there's very clear evidence of that. Now, that doesn't mean that in one's own personal experience, you don't see these sort of patterns in terms of different in terms of different dynamics. So I think it's important, even in kind of living one's own challenges, to sort of, make sure that it's clear, to sort of dispel the myths that immigrants sort of take jobs from Americans. That said, I don't have a lot of experience indirectly in sort of how clinical hiring is done, but I do know that given sort of a focus on the need for, care that's related to kind of culturally competent, I think one thing that is important is that anybody is able to give culturally competent care. And so I think for healthcare organizations, it's vital to sort of offer opportunities and training opportunities for individuals, regardless of their own race, ethnic background, because anybody can give culturally competent care. So I hope for the person asking the question that they are able to find a placement where their skills are respected and their willingness to do that is given the opportunity to thrive. And I don't think it's appropriate to sort of fall back on, just because somebody grew up bilingual doesn't necessarily mean that they're actually trained to, I myself am bilingual, but I wouldn't know how to give clinical care, right? So I think recognizing that providing clinical care to diverse populations is something that we're all capable of doing, and healthcare organizations have a responsibility to give training and opportunities for everybody to do that work.
Thank you, Dr. Young, for addressing, what we all know is a sensitive topic, but I feel like it was necessary to address given all of the misinformation that surrounds that topic as well. So again, thank you.
And yeah, so I know there were lots of comments in the comments section, but I did want to just highlight that you both really talked about this issue of um, poverty as a structural issue, something that is actually quite changeable. And I think Dr. Sachs talked about it as structural violence, and Dr. Young, you talked about it as people being structurally vulnerable as a result of poverty. And I think that's one of those things that we understand that is not the fault of individuals. However, we don't respond as a community, as clinicians, as practitioners. We don't respond in that way. And I just was wondering if you had any sort of nuggets that you can share, particularly with our students, to understand that as they kind of go down this road as becoming public health professionals, many of whom are clinicians.
Could you restate that because I'm so sorry, I got distracted.
Yeah, it was probably a gobbled question. I was just stating that you both kind of comment on this issue of poverty as structural violence and as a structural issue that is obviously changeable. However, we don't, as clinicians and as public health professionals, address it in that way. We address it as an individual problem. And just wondering what are your recommendations as how do we sort of change that cultural? These are normative. We blame people for being poor, despite the fact that, the evidence suggests otherwise and structures in place. But how do we kind of shift that narrative?
I'm happy to start. I think, one of the ways is to really to attack, sort of to intervene at multiple levels and with different audiences. And so the idea that, I mean, the full employment in a capitalist society is 5% unemployment or something, somewhere thereabouts. And so it's just a society that is essentially, it is hierarchical. And that means some people are not going to have as much as they need, as many resources as they require to survive. And so there are people who I think are pushing back against the narrative that that we don't actually have enough, right? And so I know at UC Berkeley and the Joint Medical Program with UCSF, some physicians have gotten together, medical students, along with my colleague Seth Holmes, to really try to provide this kind of theoretical and empirical training to would-be physicians to rethink the narrative around who is poor and why, and what are the causes and consequences of poverty as they relate to the healthcare encounter. So there are people who are trying to do this with medical professionals in their training.
Yeah, I love the structural vulnerability checklist. I think that is just like could help put kind of front and center reminders of these things. So I'm a public health researcher, and so working very much kind of in population um health kind of questions, but I think it's just so important to just name like over and over again. And like I loved how Dr. Sachs set up, these are societal choices, right? When we talk about immigration policy, these are choices. And I think that when we sort of name the root of where these things are coming from, it helps to just shift the focus, right? That we live in a society where there have been choices made about actively excluding people, that citizenship and lacking citizenship continues to be a legal form of of discrimination. It is lawful to discriminate people about, their opportunities for work and education because of their citizenship status. And so naming that, even as we talk about very, very individualized lived experiences, I think is important.
Yeah, you're muted.
Yeah, thank you so much. Yeah, definitely important. Definitely appreciate both of the context of sort of how you are thinking about that issue. We have a couple of questions in the chat, and one is really the question I wanted to ask too, is what are some realistic examples of community care and mutual aid? Because I think that was something Dr. Sachs talked about, and sort of a beautiful way of reminding us of what mutual aid is.
So, mutual aid can take many forms. There are many, many mutual aid organizations that have sprung up. There are many all over the state of California. There are many in the Bay. They're everywhere. So if you even just Google mutual aid and your local community, you can find many examples of that. There's a scholar at the University of Washington Law School, I believe, named Dean Spade, who has just written a book about this. But these are things that are sort of in communities of color that happen all the time. So just an example of mutual aid is people getting to in immigrant communities. People getting together and pooling money. So, for example, if you're a person who maybe has a little bit more, you might say every month I'm going to put $30 into this pot, and we're going to have 10 people that agree we're going to put $30 into this pot. And if somebody gets into a tight later in the month, they can come to the group and say, I need to withdraw everything here. I need it because my car broke down or whatever. Right. And so that's also developing this sense of, that we're in this together. Also, I know there are a lot of community refrigerators, right, where people can go and you can take whatever you need, you can donate whatever you need. But it's the idea that it's not just that people who have more are giving to those who have less, but it rests on the fundamental assumption that we all are interdependent. We all need each other, and we will inevitably all need things. And so we should be in community to share resources amongst ourselves.
Yeah, such important reminders. These are just like foundational values of, communal living, of how things used to be, right? But we do forget, and we have forgotten, particularly in these times. So no, thank you for that important reminder.
I can share one example that's happening right now, is across the state of California. Every community has what's called a rapid response network. In the case of like ICE presence, I'm going to put this in the chat. You can actually find your communities, and I think that's been a really nice that has sprung up this year, kind of, that meets different moments. And then I'm also going to put, oops, I think I shared that to the wrong. Let me share that with everybody. And I'm also sharing right now for everybody an article that I did with some colleagues, sort of really emphasizing that the community care model, something that healthcare professionals can adopt in thinking about how to respond to immigration policy and the extensive immigration enforcement that we're seeing ramping up in communities.
Great.
Thank you so much. I have a question, kind of referring back to the comment that I made about the disconnect between kind of policy and then our social context. And I think many of our students will find themselves within, either working or living within these areas. We have a good number of students who, are from California and will return to work here after they receive their clinical degrees. How would you suggest that our students bridge that gap between policy? Because of course they'll have a lot more information about the policies that are available, but they'll be practicing within these contexts that are less equitable. And so how would you suggest that they can get involved to bridge that gap?
I can take that. So I think two things. One is that policy really is made at every level. And one of the areas of, I think, small p policy that's been very important for immigrants is sort of, for example, in clinics establishing what are kind of called sanctuary policies within their own clinics. So like having a safety plan for the waiting room, which is like considered a public area, and sort of how to organize their organizational policies to create safer spaces. So I think there's that piece. But the other piece is, I know I'm a public health researcher. I'm not a clinician. Policymakers love hearing directly from clinicians. Like your on the ground experiences are invaluable. So even just connecting with advocacy groups and saying, "Hey, I'm willing to give a testimonial. I've got stories to share from what I'm seeing, HIPAA compliant stories, of course, that I'm seeing in my own clinic." I mean, those stories can do so much more than any of the data that we shared this evening. And so I think if you're willing to be a voice, the bridge is you bringing those stories to policymakers.
That sounds great. Thank you so much. And I think that dovetails really well with one of our student questions. One of our PA and PH students asked, how might a PA advocate for an immigrant patient who refuses care due to fear of documentation checks? And so I think that is a very delicate situation. So are there policies in place, or are ways that a PA can advocate?
I mean, this is not particularly my area, but I would say that there are always ways to subvert systems. I mean, you don't have to ask somebody about their status. You don't have to fill out certain parts of checklists and forms. You just maybe do what you have to do to try to get the person the care they need.
Love that. I mean, I absolutely. And I think making it clear to people in moments where they're not feeling like their status might be a question. So kind of before the fact, like at the very beginning when somebody's signing up, we do not ask for these things, or like making it clear so that it's not in the moment of like, oh, they're potentially revealing their status, sort of. So it's established, hey, it doesn't matter who you are, but if you come to this clinic, we are not going to ask for this information. Everybody is welcome here. Sort of that messaging, I think, is important. Prior to the point where they're making that decision.
Yes, I think this is such a good note to end on, and such good reminders. And I also want to just, comment on, I think it was Dr. Sachs who you opened up with, love is what justice looks like. And I think this conversation that we've had today really does sort of amplify that commentary. So thank you both so much for joining us today. And we really just appreciate this conversation, and appreciate all the commentary in the chats. And we'll make sure that we get back to, we've had some questions about getting, getting your slides to some of our students. So we'll formally request those from you after this session. So thank you all.
Thank you both.
Thank you
Thank
so
you all
much.
so much.
Have a good evening, everyone.
Good evening.
Take care.